a rich diversity of populations in the United States. It is through your generous participation in clinical trials that we are able to generate and understand the performance of our vaccines and help us make them available faster and better for all of you. Thank you. I'll pass on now to General Perna for a brief update.
Thanks, Dr. Slaoui, and of course, Mr. Secretary, thanks for the opportunity to be a part of this. So, good morning, everybody. Want to say thanks for participation. As both my Secretary and Dr. Slaoui said, it's really just important that we're able to get the message out on a routine basis. So, thank you for that. Last week, I talked about our distribution and our method. Just as a recap, we chose a whole of America approach in distribution for two reasons. One, we wanted the experts who know how to do this to help us plan and be a part of it to ensure that we had the right capability and capacity. So from Pfizer, Moderna, McKesson Trucking, through FedEx, UPS, down to the pharmacies such as CVS and Walgreens, and many others. The intent was to integrate, synchronize, and capitalize on known professionals who know how to execute this. Our cornerstone is the CDC. These experts know how to distribute vaccines. They do it annually, and we were able to take all their lessons learned over the years and apply them into the plan. Second reason we chose this whole of America approach is we wanted the American people to have confidence in the process, not to be afraid of or enamored by all the grandiose schemes, but yet just know that the common names of America are distributing the vaccine to them, and that when they have the vaccine administered, it'll be in locations that they're comfortable with, local hospitals, doctors' offices, local pharmacies such as CVS and Walgreens, or private pharmacies supporting rural areas. So again, it was about making sure we had the capability and capacity, and two, giving the American people the confidence that the vaccine will be delivered on a timely and routine manner. So today, with that said, I'd like to talk about three things. One, our allocation strategy. Two, the Pfizer testing that they've been doing in moving their product around the nation in their containers. And then three, how are we actually managing ultra cold storage? I think 3 points to highlight that would help you see the specificity of the things we're doing. So first, allocation numbers went to the 64 jurisdictions and 5 federal agencies last Friday. In fact, we hit the button at 11:35 p.m. or 23:35 military time. And that information went out to all the jurisdictions and 5 agencies through Tiberius. Each received their allocation of the vaccine so that they can plan and figure out where they want the vaccine to be distributed to. As a reminder, we are able to distribute the vaccine to any location in any jurisdiction that has been enrolled as a provider. We are not constrained by numbers. It could be 1, it could be 1,000 or beyond. As long as they are an enrolled provider and the state approves them and they have the minimum requirement of the vaccine, which is 975 doses by Pfizer and 100 doses by Moderna, we collectively, with this whole of America approach, can deliver anywhere in America to that end. Second, we have maintained a minimum safety stock, but only to assess the initial distribution of the vaccine to ensure that everybody understands the process, understands the clarity of requirements for ultra cold storage, and understands how to utilize and administer the vaccine. But once we are confident that the jurisdictions are confident, then we will release the safety stock to ensure maximum use in the country. We have provided, and we are working with each of the administration or jurisdictions right now, methods to plan and then figure out allocation within the states through the system we call Tiberius. We have been working with the jurisdictions for quite some time now, partnered at the CDC level on how to run scenarios to actually determine where they put their allocation of vaccine to the best advantage in following FDA, EUA guidance, as well as CDC, ACIP guidance. This way that leadership of the state has the maximum capability and capacity to plan, look through different scenarios, and then make a final decision to best impact the people of the United States. Really powerful system to help us lead our way through execution and not react. We will be sending, after we send the initial push of the vaccine here, pending EUA, then we'll be on a steady drumbeat of sending allocations to the jurisdictions every week. Right? We'll allocate vaccines. Jurisdictions will be allowed to go in 24/7 and order and distribute the vaccine to where they want it. And then the following day, we'll be able to get it to the locations that they designate. Really hard work, great collaboration with both HHS, Department of Defense, and industry to get this right. But I'm very, very confident that we have a solid plan and that we have the ability to observe, watch, monitor, adjust to meet the requirements as been specified through the states. So very difficult challenge. We're working on this constantly. We work rehearsals of different scenarios to make sure we're capturing all the nuances of the delivery, but each and every week we get stronger. It's not lost to anybody listening. We're 1 week closer to distributing the vaccine. We're 1 week closer to refining to the exactness that we need to have to do this, and I'm very confident in that process. So the second thing I'd like to talk to you about is the Pfizer-initiated tests. Really remarkable. You know, we do this all the time in the Department of Defense. It's one of our strengths. We know how to plan. We know how to rehearse. I was equally excited to watch Pfizer and Moderna go through similar processes to make sure that their product is right to begin with, but most importantly, we can get it where it needs to be when it's time to get it out to the American people. Pfizer is really implementing a very aggressive approach to figuring out how to get their product out to the administration sites as designated by the states. They're running dry rehearsals, as we like to call it in DOD. This way, they run through the actual process of registering product through a jurisdiction. Then they deliver the product. Then they walk the administration sites through the actual opening and how do they manage the product out of the container. Really powerful to watch and see people learning. Pfizer is capturing lessons learned, and they're putting it in training product fact sheets, as well as creating YouTube-like videos for everybody to observe and monitor. We started small at 4 locations. We recently expanded to 10 locations. We are going to go to the remaining 54 locations to ensure that everybody has an understanding of this. What we have found in general is initial hesitation once the product is received, but as Pfizer has walked the administration sites through the execution, we see growing confidence in everybody that's using it. And that has been the story throughout every rehearsal so far. Again, we have to walk through everybody to make sure everybody's confident in it, but I personally have gone through the process. I've actually put my hands in the box, I've pulled trays out, I've watched, and I've timed myself in execution. It is a very, very doable process. Our professionals, both medical, at the medical level and then at the pharmacy level, are very well versed on how to do this. It is not the first time, and I feel the confidence in the reinforcement through our rehearsals, our training products, and then actual execution will create a steady level of confidence for the final, full, and complete administration of the vaccine. So well done by Pfizer. and Moderna getting ready to do similar acts accordingly. So last but not least, it is about the ultra-cold storage of the vaccine. We've all heard Pfizer vaccine has a requirement of minus 80 degrees, right, at ultra-cold storage. This freezer is important, but not to a limiting end. In other words, Pfizer has created a container which is augmented with dry ice that maintains the vaccine at the appropriate level. In doing so, they've enabled the extension of vaccine storage at the to maintain the right stability for up to 20 days. Really a tremendous effort, as I just described in the training that they're doing, to ensure that the vaccine is available and stable and appropriate for administration. And we feel confident that if states plan to the right dosage at the right locations, that the drumbeat, the cadence, the administration of vaccine to the minimum amount, which is 975 doses, is very doable within the 20 days. Clearly, we have to have a plan. Clearly, we have to hold ourselves accountable to administering that, but it is a plan that can be done, and we feel confident in talking with the jurisdictions that they've worked through these details to ensure that the vaccine is used appropriately and without any waste, which is the biggest important factor for us. So, a challenge, yes, but it should not hold us back from administering a very good vaccine to the American people. Moderna is a different case. They're at minus 20 degrees. Minus 20 degrees is equivalent to a normal kitchen refrigerator freezer or a freezer that is most commonly found in most pharmacies, etc. It has greater stability in that it can go into the refrigeration for up to 30 days. Yes, so it becomes a vaccine that its administration becomes easier to do, and it will enable us to get to many places throughout the country, as we've talked about before, from inner city out to rural America. It produces an advantage to that end. But I will tell you that I believe the jurisdictions are ready. They've been well informed on the information of both vaccines, both requirements for cold chain storage. They have added capability and capacity as required. They have trained people to administer it. They have contacted pharmacies for support like Walgreens and CVS to help them. And we are well on our way to successfully administering both vaccines to the American people in the near future. So, Mr. Secretary, that concludes my comments.
Thank you, General. And at this point, we'll take questions from the media.
As a reminder, this call is recorded. If you would like to ask a question, please press *1 from your phone, unmute your line, and speak your name clearly when prompted. Your name is needed to introduce the question. Please limit to one question so we can try to address all questions today. If you would like to withdraw your question, please press *2. Again, if you would like to ask a question, please press *1. One moment, please, as we wait for any questions. Our first question will come from Helen Branswell. Helen, your line is open.
Thanks very much. This is probably a dumb question, but can you talk us through the logistics of how this will work? Somebody, a hospital in, say, Reno gets 995 doses of the Pfizer vaccine. Are they meant to then try to vaccinate 995 healthcare workers as quickly as they can, or are they supposed to reserve half of that tranche so that they can give that group of people their second vaccine later? If not, how can they be assured that they're going to be in the right place in the line to get the second dose when those people need their second dose?
Okay, so what we're working with is the states have really worked their micro plans on the final distribution, and that's what they're actually putting into place over the next 2 weeks in preparation for EUA. And they're specifying, they've identified amounts of providers. Providers can be everywhere from local hospitals, doctors' offices, pharmacies, etc. As long as they're enrolled, we can distribute to them. In their plans and with their identified priorities, they will specify how they want to administer the vaccine. So in your example, let's say one tray from Pfizer vaccine goes to a hospital. It has 975 doses in the tray. Vials can be taken out of the tray, right, every single day and brought down to room temperature for administered. It's not a requirement to do all 975 in one day or 1 week. They have, as I talked about, up to 20 days to really administer those 975 doses to ensure that they can get the right people in the right places at the right time. Currently, right now, our plan is to initially distribute the first dose vaccines to the states, and then on a second delivery at 21 days for Pfizer and 28 days for Moderna, the states will receive the vaccine for the second dose. There is methods from very simple, here's your card, come back on this day for your second dose, to very elaborate automated plans at both the state and national level to ensure reminders are sent and the vaccine is available for the persons. We are continually to assess the manufacturing of the vaccine, and we think that once we have a really steady, confident cadence in manufacturing in the very near future, there's potential to just vaccinate at maximum allocation because we have confidence that the second dose will be available accordingly. We're just starting this way initially to ensure that everybody understands the process and we can be accounted for. Thank you.
Next question, please.
The next question is from Zach Brennan, Politico.
Hi, thanks for taking the question. So can you talk a little bit about the timing with the ACIP recommendation after a possible EUA? Will states be able to adjust where the first round of doses will go based on the ACIP recommendations, even if you're shipping, within 24 hours after the EUA?
Yep. So, Zach, I think it's important to understand the nature of ACIP's role. This is for other members of the media. This is the Advisory Committee on Immunization Practices, which is an advisory committee set up under statute that's used by CDC Connected, usually the Vaccine for Children's program. The ACIP has, of course, a very important role in that when they make a recommendation for a group to be vaccinated, that they say essentially that the efficacy outweighs safety risk for vaccination and they recommend vaccination, that triggers various reimbursement mechanisms in our system once there's an ACIP recommendation. As we have with the National Academies of Science, we've worked with the Advisory Committee on Immunization Practices in addition to their statutory obligation on that binary recommendation to vaccinate. We've also sought any insight, input, et cetera, around when dealing with a scarce quantity vaccine, which groups, which cohorts to prioritize. At the end of the day, that is a decision, though, of the U.S. government to make, which is where to recommend the prioritization. And in the final say, it will be our nation's governors in implementing the distribution plans to tell us, as General Perna has repeatedly said, where to ship, and they will decide whom the vaccine is given to. We hope that our recommendations will carry weight with them, but at the end of the day, they will make that decision. And so we are not dependent on any delay for ACIP in terms of helping to advise states on that prioritization. We received some information just yesterday from ACIP. We had received the National Academy's input previously, which is still going through some public comment with them. But we will work, we are working expeditiously to formulate our recommended prioritization for vaccine distribution based on where we can secure the maximum effect under whatever the current epidemiological circumstances are in the United States at that time. Thank you. Next question, please.
The next question is from John Cone. John, your line is open.
Thanks so much. The company has been less than transparent about how the half dose occurred, and I'm wondering whether they explained to you what happened, and also whether you have plans to switch to half dose as the prime for the AstraZeneca Oxford trial.
Yes, so we have been made aware of what's called now the half dose at the time it has happened. This was a change in the way the quantity of vaccine, the amount of vaccine put in a vial was tested. And when they realized that there was an error or a change in the approach, in the technique used, they corrected it. And in the meantime, about 3,000 subjects were recruited, half of them in the placebo and half of them in the vaccine group. And that's the cohort that has shown 90% efficacy. That's, I would say, the fact in terms of what has been inputted into the vaccinees. What we are now looking to analyze is what immune response has been induced in those who have received the half dose and the full dose versus those that have received twice the full dose, and understand whether there are differences in the immune response induced. You should also know that there are also differences in the age brackets present in the cohorts, in that the first cohort that received the half dose and full dose, followed by a full dose, had a cap on the age at the age of 55, when there are older people included in the study that received full dose and full dose. So there are a number of variables that we need to understand, and what has been the role of each one of them in achieving the difference in efficacy. Once we understand, then we'll make a decision as to whether to, for instance, modify in part the ongoing phase 3 trial here and introduce, for instance, a half dose and full dose, or any otherwise. But we want it to be based on data and science, because we understand the input, but we don't understand the consequences of the input. I should just say, for completeness scientifically, that the 90% efficacy group and the 62% efficacy group are overlapping statistically, so it is still possible that that difference is a random difference. It's unlikely, but it's still possible that it's a random difference. So we need to understand what's behind it scientifically.
Thank you. Next question.
The next question is from Carl O'Donnell. Carl, your line is open.
Hi, this is Carl O'Donnell from Reuters. You mentioned that you had given some guidance to the states in terms of the general size of the initial allocation of vaccine that they're going to get to help them prepare. Do you have a national figure at this point for the amount of vaccine that'll be distributed overall to the different states and jurisdictions? And what is that figure, and are you confident that we'll still get to the 40 million figure overall by the end of the year?
So yes, I do feel confident that we're going to get to as close as we can to 40 million at the end of the year. I mean, snap the chalk line, what exactly comes off, we'll know at the end. But I do feel confident, and we've planned scenarios to that end, and we've worked with the jurisdictions for the total amount through December. The initial amount, as we were speculating on when EUA would come out, because we're not involved in that process, literally on the whiteboard, we're trying to figure out when that decision might be made. I finally made the decision Friday night, late Friday night, to snap the chalk line so states could prioritize based on amount. That amount that we allocated to the country was 6.4 million doses of vaccine. And then what will happen if there's more available after the initial push, then it will go out in the following weekly cadences of distribution accordingly. But yes, 40 million by the end of the year.
Next question, please.
Next question is Dan Bergano, BuzzFeed News.
Thanks very much. I'm wondering if you have any concern that the general population will be disappointed when they figure out the prioritization is going on, that it's going to healthcare workers and nursing homes, that sort of thing, and not to sort of the general public until it sounds like months from now. Months have been discussed, like April to June, thereabouts. If you had any guidance on that as well, that would be great. Thanks very much.
Well, Dan, we've been very transparent throughout for the American people and for you all about the timelines as we best understand them at each step of the way and potential prioritized groups. Of course, we have not announced recommended prioritization. We've talked about some core groups that make some fairly obvious sense, especially in light of the National Academy's input and the Advisory Committee on Immunization Practices focus. Those, of course, are those in nursing homes, as you mentioned, our most vulnerable citizens, our healthcare workers who are on the front lines, our first responders. Those are some of the broad groups we've talked about. And we've focused and we've said that we expect by the end of December to have enough vaccine to vaccinate those who are most vulnerable, just by way of sizing and scaling. That by the end of January, we think we would have enough to vaccinate our senior citizens as well as our healthcare workers and first responders. And then, as the General has talked about, progressively, week after week, just more vaccine keeps coming off of the production, gets quality controlled and released into the system, additional prioritized groups, or eventually just general vaccination availability, to the point that in the second quarter of next year, we believe we'd have enough vaccine from all sources to be able to make that so that anyone who wanted to get a vaccine in the United States would be able to get that. But that's a progression, a constant progression. And so we've been very clear for months, really, about that sequence. And that's the best we can do, is just to use forums like these and others to educate in that regard.
We have time for 3 more questions.
The next question comes from Tom Howell, Washington Times.
Hi, thanks for doing the call. This question is probably for the Secretary. Earlier in the year, there were some polls that showed some people were leery of taking a vaccine. Some of that was tied to campaign timelines. Now that the election is over and now that some data is coming in that shows these shots are quite effective, how confident are you that people will be eager to go take up the vaccine, and what are you doing to ensure, to alleviate any skepticism, especially among minority populations? Thank you.
Yeah, thank you very much, Tom. Excellent question. You're right. We saw ever-increasing numbers of potential vaccine hesitancy in previous months. Unfortunately, there was a lot of rhetoric out there that was not helpful in terms of inspiring confidence in the process. The President and I have been clear that politics would play no role in the development, the manufacture, the distribution, or approval of a vaccine. I think the proof is in the pudding there, that we have all of these various checks on independence in the system. I've talked about 5 separate checks. The Data and Safety Monitoring Board that determines even if the drug company gets to see data. The drug company's own ethical checks, where they determine if they even find the data to meet their ethical standards to submit for approval. The fact that the FDA has laid out both final biologic license as well as EUA guidance on what standards they would hold a vaccine applicant to. The fact that the FDA would hold a public advisory process with their Vaccine Advisory Committee that is an independent, transparent, public process. They've already announced on Friday that December 10th will be the date for the Pfizer Advisory Committee. And then finally, the fact that FDA career scientists, career leaders, will make the ultimate call on whether a vaccine meets FDA's data, scientific, evidentiary, and legal standards for authorization or eventual approval. We have seen, since the Pfizer and Moderna data have come out with such exceptional results, and of course, with the passing of the election, we have seen in public polling increases in vaccine acceptance among people. We obviously remain concerned, especially in various underserved communities, about any issues of vaccine hesitancy. The CDC, our Assistant Secretary for Public Affairs, as well as all of our public health leaders, are working on a public service announcement campaign that would work to educate the broad population regarding the need to be vaccinated, the safety of the vaccine, the efficacy of the vaccine, the importance of getting vaccinated if you're in one of the target prioritized groups. And we'll keep doing that. And I think progressively, as more and more people get vaccinated over time, the prioritized groups moving forward eventually to general vaccination, hopefully there's a positive experience for individuals, and that by word of mouth, in addition, of course, to all of the education efforts, we continue to reduce vaccine hesitancy and continue to increase support among people to get vaccinated. I've told you, I certainly will have complete confidence in the process, and I will get myself vaccinated as soon as I will be allowed to be vaccinated to demonstrate to the American people my complete confidence in the independence and integrity of the process and the quality of any vaccine that I would make available to the American people. Next question.
The next question is from Andrew Dunn, Business Insider. Andrew, you may begin.
Thank you. I was wondering, what do you see as to put it simply, the ultimate responsibility of states in the distribution process? Can you go over clearly what jurisdictional public health leaders will need to do as part of the campaign? And have you heard from any states or regions about a need for additional funding to actually make that happen at the state level?
Yeah, thanks. I'll start and I'll ask General Perna to add to it. This is obviously, as we talked about in our last call, there are two types of partnerships here that are involved. The first is the public-private partnership of what we're trying to do to really leverage the systems around vaccine distribution in the United States that are well-rehearsed and that work. We want to make the experience for people as close to the flu vaccination experience as possible in terms of meeting them where they are. The second is a federal-state partnership, very tight linkage between us. We have gotten the vaccine. We are paying for the vaccine. We are paying for the distribution of the vaccine. We have secured the kits that go with vaccination. That's the needles, the syringes, the diluent, the last-mile dry ice, etc., to marry that up with the vaccine. We have the data systems for distributing the vaccine as well as for accounting for the immunization of individuals, the tracking of individuals to ensure they get a second dose of the same vaccine. What is the role of the states? Of course, the governors will determine distribution within their states, prioritization within their states, where to ship to. As the general has said, we can ship to one site or 1,000 sites in a state, depending on the governor, as long as they're enrolled in the system, and the governor tells us what he or she would like us to do. That's one. Tell us, as almost an air traffic controller, where would you like us to send or have sent the product? The second is ensure your data systems are working with ours and that you've signed data use agreements to ensure the ability of coordination of information across the United States, so that if somebody gets vaccinated with the first dose in New York and they then go down to Florida for the rest of the winter, they can get their second dose in Florida, and if it was Pfizer, it remains Pfizer. If it was Moderna, it remains Moderna. The states will obviously, if there are additional areas that they would like to ensure distribution to beyond the normal traditional mechanisms that we've worked on, hospitals, chain drugstores, community pharmacies, community health centers, public health departments, if governors feel there's a need for customized other approaches, they are fully at liberty to set those up. That is part of them being in the driver's seat on that localized micro distribution planning. We've put out $340 million for flu and COVID-19 vaccination to date. Another $140 million is going out in December. Money should not be the barrier to effective, efficient distribution of the product, working with the states, but it is important to remember just how much of this entire process is already federally funded and federally supported in partnership with the states. General?
Mr. Secretary, I am 100% agreement in everything you said and have nothing to add.
Well, thank you, General. One last question, I believe, Michael? Thank you.
The next question is from Jared Hopkins. Jared, your line is open.
Thanks. Jared Hopkins from the Wall Street Journal. Regarding allocation, previously the CDC said that besides population, local spread of COVID was going to be a factor for determining for each state. So can you explain sort of how you guys decided on each state's individual allocations within that $6 million that you mentioned earlier? Is it based on infection rates from Friday or something else?
Yeah, so Jared, you know, given the national spread of the disease at this point, and unfortunately for the foreseeable future, working and seeking consultation with the governors. We asked the governors for input on allocation methodology. We didn't receive feedback from many, but the feedback we did get was supportive of what we proposed, which was to keep this simple, and on the initial allocations to follow a per capita over the age of 18 population-based formula for distributing the vaccine. We wanted to keep this simple, first because we're seeing effectively nationwide spread and susceptibility to the disease, but also once we pass through these initial tranches where we're in much more of a scarcity situation, we're eventually going to get to the point where it would need to be per capita, and so instead of having multiple methodologies, we thought it best to keep it simple. The governor supported that from the feedback that we received, so that was the approach we took, correct, General?
Exactly right, Mr. Secretary.
So we thought that would be the fairest approach, the most consistent. I want to thank you all for this. We're going to keep doing this weekly or as much as needed. We want to make sure that you're getting your questions answered, that we're being transparent about our Operation Warp Speed work on therapeutics, on vaccines, on distribution practices. I was not asked about this, but I do want to let you know that consistent with the GSA administrator's ascertainment yesterday, last night, our top career official, Rear Admiral Schwartz, who has been leading our transition planning efforts, was last night in communication with the Biden transition team. We are immediately getting them all of the pre-prepared transition briefing materials. We will ensure coordinated briefings with them to ensure they're getting whatever information that they feel they need that's consistent with statute and past practice. I have reiterated, as I've said publicly to you all, I reiterated to Admiral Schwartz my firm commitment that transition, planning, and execution will be professional, cooperative, and collaborative in the best spirit of looking out for the health and well-being of the American people, and in particular, saving lives through this COVID-19 pandemic. I want to say, again, just thanks to the support, unwavering and constant and personal support that this team has had from President Trump from the beginning to create Operation Warp Speed, to give us the full funding of resources and the independence to act with speed and agility. We now have phase 3 data on 3 vaccines, 3 more vaccines in active study. 5 therapeutics now are authorized or approved by the FDA to help people suffering from COVID. So much is already here, so much is on the way. As I say, hope and help are on the way. But that also means we're bridging right now. We're bridging to when we have these vaccines that General Perna is going to ensure are getting out there to our most vulnerable and to our healthcare workers and our first responders and eventually the broad American population. It means we need to bridge through our individual behaviors. We want to make sure that everybody can get to the day of experiencing the benefits of the work that that team is delivering. And that means wash your hands, watch your distance, wear your face coverings when you can't watch your distance. Stay out of settings where you can't do those things. Be especially mindful of indoor gatherings, especially those where you might let your guard down, like household gatherings, overcrowded indoor restaurants, indoor bars. Especially now, as we approach Thanksgiving, I ask all Americans, please be on guard, take care of yourselves, be careful, because there is such a bright day ahead with what this team is delivering on vaccines and therapeutics. We want to make sure that everybody is here for next year's Thanksgiving. So thank you all very much, and members of the media, thank you for helping us in our efforts to ensure the American people go on this journey with us. Thank you.
Thank you all. You can send any follow-up questions to our press office at media@hhs.gov. Thank you all for joining today's briefing.